Good afternoon, all, and welcome all. Today's our third CME lecture series, actually, for this year. And without taking much time, I would like to introduce our new speaker. She's known to all of us. She's our consultant anesthetic. She's been for a few months with us here, and she will talk on you a bit of uh, this is a common topic, but most probably, hopefully, she will touch a lot of untouched areas for us in this lecture. Without taking much delay, over to you, Vikasini.
Thank you, Dr. Pradeep. Very good afternoon to you all, and welcome. I welcome you all to this third CME lecture. My lecture today is on sepsis. As he said, it's a very common topic, but here I would like to focus more on recognizing septic patients and how to administer the early management to this deteriorating patient. So my topic or the content of today's lecture will basically uh, based on two guidelines. One is the Surviving Sepsis Campaign Guideline, which is published in 2026. And the other one is the UK Sepsis Trust Guideline. And their guideline was published in 2024, the last one. And they brought up this Sepsis 6 bundle. So I will give that to all during this lecture. So at the end of the lecture, I think we will have an idea about recognizing sepsis early. Here we are going to assess the patient clinically as well as use the new scoring systems like NEWS, that is early warning scores. There are national early warning, and then we have modified early warning scores, and also how to use the blood investigation like lactate and renal and liver functioning identification of sepsis, and also not relying on the screening score alone, but also looking at the picture as looking at the patient as a whole picture when we are dealing with the septic patient, and also deliver the sepsis 6, that is it is similar to our one bundle in earlier managements, and also how to escalate the patient after initial resuscitation. And also I can't deny the fact of administrating the proper antibiotic on correct time, and also the source control of this patient. So why sepsis matters? And as you know, sepsis is very common. Every day we see a lot of people in our wards with sepsis, and also it is very lethal, but unfortunately it is frequently missed. When you look at the WHO data, you see that about nearly 48%, 48.9 million people are admitted every year with sepsis. Out of that, about 11 million people died of sepsis. That means that there's a huge mortality burden with sepsis. When you consider all the deaths, about 1 in 5 deaths are due to sepsis. So there is a huge mortality burden associated with sepsis. And when you consider the mortality, when survivors, when you consider the survivors of sepsis, survivors also affect in many ways. Many have body weaknesses, and many suffer from cognitive impairment, and they have a lot of psychological impact after sepsis also. And they are tend to admitted to the hospital with recurrent infection and other morbidities. And the other important factor is the time-dependent nature of the sepsis. Whenever you consider sepsis, we are talking it as a time-dependent medical emergency. That is because the patient with sepsis deteriorate very quickly. They are come with infection. Then when the sepsis began, there will be a dysregulated host response. And if we do not intervene, the patient develop into organ dysfunction, and if you still your management is not proper, they will go into shock and ultimately die. So it's a time-dependent deterioration is there with sepsis, so it is very important. But unfortunately, we are frequently missing these patients in our wards, and it is not only in our setup. Globally also, these patients are misdiagnosed. let us recap the definition of sepsis. So when you consider infection, infection merely says that there is a microbial invasion and there is a clinically suspected infection is there. But what is sepsis? Is it similar to infection? Yes, it is similar to infection, but the host response is dysregulated. So it gives rise to life-threatening organ dysfunction. The one thing that memorize, can you remember? We memorize the sepsis as life-threatening organ dysfunction caused by dysregulated host response, isn't it? So there's a dysregulated host response to the infection, and it causes organ dysfunction. Okay, so when you in clinical setup, we are saying that there's a suspected infection and the acute SOFA score is more than 2, that there is a sepsis, isn't it? And what is septic shock? Septic shock is a subset of sepsis. Okay, subset of sepsis, but there is a profound circulatory, cellular, and metabolic derangement in this patient. So in clinical setup, we see that if the patient is requiring inotropes to maintain a MAP of more than 60 to 65, we say, okay, that the patient is in septic shock. And also, despite adequate fluid resuscitation, if the patient's lactate is remaining more than 2, again, we are saying, okay, the patient is septic shock. So practical bedside question is, when you see a patient, so we are going to see, okay, whether this patient is having infection, or whether this patient is having an infection plus organ dysfunction, or this patient is having a hypoperfusion or is in the shock state. So you're going to practically see what is the state of this patient whenever you see a patient suspecting a sepsis. Okay, when you consider the pathophysiology, we are considering sepsis as a syndrome. It is a syndrome of immune, endothelial, and microcirculatory failure. As I said, when you have an infection, what you usually get in a normal patient is a regulated response. But here what happens when you have a pathogen, but the host is mounting a dysregulated response. So there will be so what is the first system to activate? It is the innate immune system in the body, isn't it? Whenever there is an infection, there is an activation of innate immune system. In sepsis, what happened is that there is the surge of complements and activation of coagulation pathway. So whenever you have a sepsis, you say that there is a cytokine storm. Okay, this cytokine storm or the dysregulated activation of immune system basically disrupt your endothelium. Not only endothelium, but there is a glycocalyx around it. Because of this activation of dysregulated immune system, your glycocalyx also disrupted. So what happened to endothelium? Endothelium can become leaky, and also endothelium also become dilated and it started to develop vasoplegia. Vasoplegia means that it's not visible. It is not going to respond to your usual catecholamine in the system. So you are getting a leaky vasodilated capillaries. Okay, that is one part. The other part is there is a dysregulated coagulopathy in this patient. These patients tend to get small microthrombi in their circulation and they are going to dislodge into your small microcapillaries. So even though your perfusion pressures or the volume status are all right, your peripheries are not receiving enough perfusion. And the other one is that there is a global mitochondrial dysfunction in sepsis. So even though your perfusion is adequate, even though you administer your oxygen properly, the mitochondria is unable to utilize this oxygen. So you will have rise in lactate. So the inflammation of the endothelium with coagulopathy and the mitochondrial dysfunction give rise to the sepsis and as a syndrome. So there is ultimately immune, endothelial, and the microcirculatory failure in sepsis. Okay, so this is the most important slides in this lecture because sepsis is starting as a deterioration. Okay, so it is one of the commonest cause of patient deterioration in the world, but we often missed it. Okay, so sepsis starts as a deterioration and it is a clinical diagnosis. You do not have to wait for the laboratory investigation to identify that your patient is septic. So you don't have to wait for your CRP or the full blood count to see that this patient is going into a, is going to a sepsis. Okay, so it's a clinical diagnosis. So when you have a patient who is having suspected infection, you see that the patient's physiology is changing, and then if you do not disrupt or interrupt, the patient may slowly go into organ dysfunction and ultimately the shock. So what do you have to look at the bedside? So you do your clinical evaluation properly. So you have to look at the respiratory system, look at the respiratory rate. So respiratory rate, they say is one of the earliest signs of sepsis. So I said that there is a microcirculatory failure and there is a mitochondriopathy. So what happened? There is a lack of oxygen in the body. So what is the response? There is a reflex mechanism to get more oxygen. So ultimately, your respiratory system is the first system to respond in sepsis. Okay, so they tend to be tachypneic. They are working low. The respiratory work is increasing. So if you find a patient with your lower limb wound, but the patient is tachypneic and is out of breath, and but there are no lung signs, then there is a suspicion that the patient is going to sepsis. So other than the respiratory system, the patient may require further oxygen. Their saturation may going down and you need to give oxygen to these patients. So there can be tachycardia, hypotension, and GCCS also can go down. Okay, and also there can be features of the renal system involvement in this patient. So bedside the examination is very important rather than depending on your laboratory investigation. And also there is tracking trends also very important in identifying sepsis. That is something that I'm not seeing in currently in this institute. So tracking trends mean that they say that one clinical parameter not give you a good idea about the patient condition. But if you look at the trend, what is happened to your heart rate over the time? What will happen to your blood pressure over the time? It will give you a clear idea of the clinical state of the patient. The other one is that many patients will not have fever, especially elderly patients and immunosuppressed patients. They are unable to give rise to fever. So they will have no fever. Okay, especially diabetic patients, they can go into sepsis without having fever. And also hypotension is often late. If you find that patient is hypertensive and start on vasopressors and then say, okay, that this patient is septic, you are too late. And also, especially if you see a patient who is look unwell, you have to think rationally and do your thing. So what is your immediate response? Your ABCD has to be assessed, and then you use your screening scores like early warning scores. I will go into those things later, and also screen for sepsis. Okay. So what are the early warnings or the red flags in sepsis? These are the features published in that I told you about the Sepsis Trust, the guidelines. They have given us early warning on the red flags. These are to recognize the high risk infection or features before irreversible shock. So if you see a patient with septic foci and have these signs, you have to have an idea, or you have to have in your head that this patient is in a critical condition. Patient with possible infection is deteriorating, is developing new confusion or reducing GCS is a one red flag. The other one is tachypnea and decreasing saturation. If the patient is unable to maintain the systolic blood pressure or the MAP is another feature. And if the lactate is rising, that is also another red flag. Other than that, there's oliguria, motors fluid with cyanosis and poor capillary filling time, hypothermia or hyperthermia, as well as immunosuppression, pregnancy, frailty, and also post-operatively also patient are at high risk of developing sepsis. So these are the red flags, and these are the patients who are at high risk of infection, or the high risk infection. Okay. Other than that, the other thing we can do to recognize the deteriorating patient is tracking the patient. To do that, we have early warning score. So we have news score, and then we have modified early warning score. News is a national early warning score too. And other than that, we have a modified early warning score. These are track and trigger system because they are tracking the physiological parameters, and they are tracking and see what is happening to these parameters over the time. So the important thing is after tracking these, the score system giving us a trigger also. What to do if this is happening? Okay, I will show you to that. So in news 2, they have 6 physiological parameters. They are measuring respiratory rate, saturation, systolic blood pressure, pulse, temperature, and the consciousness level. And also there's a 7th parameter, that is whether the patient is on oxygen or not. Okay, so over time they are going to measure these things, and after that they are giving, now the 0 mark is usually the physiological normal. If there is a deviation, whether if it is rising or decreasing, they are going to give us a mark. Okay, and the first one is respiratory rate. The usual one is about 12 to 20. If the respiratory rate goes more than 25, they are giving a color mark, that is 3. And also if it is going below 8, that is also is reducing. Okay, so it is not only giving a mark, it has a color code system as well. Okay, so there is a yellow, amber, and red. So if the patient is in white area, patient is safe. But if it is going along the yellow, amber, and to the red zone, that means that the patient is in the high risk zone for deterioration, that you have to act quickly. Okay, so when you consider the marks, so according to the mark, they are categorizing the patient to low risk, medium risk, and high risk. If the news 2 is more than 7, that is high risk patient, high risk of deteriorating, and you need to see the patient to the seniors, and you have to have a critical care or HDU management. And if the patient is having a news score of 1 to 4, that means that it is a low risk patient, that you can safely keep this patient in the ward. Okay, so this is I told you this is track and trigger system, isn't it? This is how we track it. So according to the time, how the patient's the clinical variability changes is tracking along the graph. So if the patient who is in white area is going towards the amber and to the red, that means that the patient is deteriorating. So this tracking system, tracking and triggering system is actually more, they have found that these systems are actually better than the one, rather than like the nurses via the pink chart. These are actually better because we have a visual identification of deterioration in front of you, isn't it? And also they have a trigger system also. According to the mark and the color, the code, they are giving how frequently the patient need to be monitored and what is the clinical response. So if you are in the red zone, or if your news score is 7, it says that the patient need continuous monitoring. Patient has to be shown to the seniors, patient has to be transferred to the HDU and ICUs. Okay, so these has to be monitored and treated very quickly. So this is something that I think that we are lacking in this institution. So if you can implement this, I think we can have a better patient outcome, isn't it? So that even if you change your shifts, so that if you can just plot, both nurses and doctors can accumulatively do this. So if you can track this patient in front of you, there is a visual way to see that the patient is deteriorating or not. So I think this is something that we can implement in this institution. So then I think that we can provide a better care to the patient. Okay. Other than that, I said there are various other scores. So there is MUSE, is that there's a modified early warning scores, and there is QSOFA and there's SIRS, and also there are SOFA score for organ to identify the organ dysfunction. So practical, one other thing is that although there are scoring system, it's always the clinical judgment that has to be prominent, isn't it? Your clinical judgment or the clinical the identification cannot be replaced by this scoring system. So after screening, how are you going to proceed in sepsis patient? So you are suspecting. So there is infection plus deteriorating patient, and you're going to screen the patient with your early warning scores, and you identify that the patient is in sepsis. Then how are you going to proceed afterward? When you're going to assess, you're going to do your ABCD, and you do your basic blood investigation, and you give your treatments, antibiotic as needed and fluid as needed, and then you reassess the patient and you see whether you need to escalate this patient or not. Okay. And so when you, after screening, after assessing, how are you going to treat this patient? Earlier we have our one bundle. Our one bundle was 2021, the Surviving Sepsis campaign. They brought 2018. They brought up the our one bundle. There, you know that we have 3 things to be given and 3 things to take out. What are the 3 things to give? You are giving antibiotics, you are giving fluids, and the vasopressors. 3 things to come out. What are they? It is the cultures, urine output, and urine output cultures, and something is taken out. But it is now they have actually modified it. Now the other, they are not talking about the other one bundle. They are now talking about the sepsis 6. What is the importance of it? The first one is a senior clinical opinion. They have incorporated the senior clinical opinion to this our one. That is because you know that I said that the sepsis is a time critical medical emergency with high mortality and high morbidity, isn't it? It is the most commonest cause of patient deterioration in the ward. So we need to get our senior opinion to reduce this mortality and morbidity. That is why they have informed, if you identify a deteriorating patient, if your patient is in the red zone of news 2, that you have to inform your seniors and get their opinion to this patient. Okay, so the first one in this sepsis 6 bundle is getting the senior opinion. You have to inform, you have to take the others' opinion to reduce the mortality and morbidity of this patient. Then the other things are coming. Give oxygen if needed, obtain an IV access and take bloods. So what are the things you are doing with these bloods? So first thing is you have to get blood for cultures. Do a VBG at least to see the lactate level. Then you have to do the full blood count, CRP, and you have to have the baseline of renal and liver functions. Okay. Do the blood urea and serum creatinine with serum electrolyte and full liver profile. And glucose has to be monitored because with sepsis there is an imbalance of glucose level. So glucose has to be monitored, and also basic clotting profile has to be done in this patient as a baseline. Okay, so those are the things that you do with those bloods, and you have to get the IV access. And the other most important thing is giving IV antibiotics, and you think about the source control as appropriate. And the 5th one is giving IV fluids, and then you continue the monitor with the news 2. News 2 does not monitor the urine output. That's why they are separately putting urine outputs also. News has 6 parameters I said earlier. It does not have urine output there. So that's why they, other than the news 2, urine output has to be monitored, and also all the investigation has repeated appropriately. So those are the other one bundle, or the sepsis 6, where they are emphasizing the importance of senior clinical attention in sepsis management. Okay, now we are going to see how I am going to give fluid to this patient. So fluid is very important. Why? I said that in the pathology there is a endothelial dysfunction. One thing is there is endothelial leakage, and there is profound vasoplasia in this patient. So because of that, these patients are, one thing is there's a relative dehydration, and there is a profound vasoplasia. So their blood pressure is going to be reduced. So how are you going to treat this? We are not going to treat this, but we are going to support this patient who has this critical endothelial dysfunction. So the first line is giving fluid. So over the years, with evidence, they have identified for the septic patient, we need at least 30 ml per kg of crystalloid during the first 3 hours. So imagine now your patient is about 50 kilograms. So at least 1.5 liters of crystalloid has to be given within the first 3 hours. That means roughly about 500 ml of fluid has to be given per hour for 3 consecutive hours to achieve this. That is for a 50 kilogram person. Okay. So if the patient is having a high BMI, you're going to calculate the ideal body weight and infuse it. Okay. So when you are giving the fluids, it is the crystalloid is the first line. And out of that, the balanced crystalloids is the evidence-based one, but we do it's plasmolite is the balanced crystalloids available, but we do not have it. So we are going for 0.9% saline. So in our setup, if a 50 kg person coming with sepsis, we are going to give 0.9% saline, about 1,500 ml during the first 3 hours. Okay. So what are the things we have to worry when we are giving fluids? When you are giving fluids, you have to frequently reassess whether we are over-resuscitating the patient. Okay. And also, especially when you're in setups, in our setup, we have 0.9% saline as well as Hartmann's. But if the patient is having a traumatic brain injury, it is 0.9% saline that is we have to give. Okay. And the other one is in sepsis, we are avoiding starches and gelatins. And albumin also not encouraged. It is only be given if you are infusing large volume of fluids, just to take, because it has some colloid pressure is there, just to entrap your fluid more in the compartment, you can give albumin, but it is not routinely recommended. Okay. So that is about the fluid, and this is very important. So whenever you receive a patient, please give fluids. Okay. So about 30 ml per kg, that is for a 50 kg person, first 3 hours, at least about 1,500 ml of fluid has to be given. Okay. So how are you going? After initial treatment, you have repeatedly asked, is perfusion improving? Okay, because there is a risk that we are under perfusion, or there is a risk of over perfusing also. So the question that you ask repeatedly is the patient is improving. Okay, so the fluid responsiveness, measuring fluid responsiveness is very important in that aspect. So in the guidelines says you go for the dynamic parameters. So in the hemodynamics, in measuring our blood, the circulatory system, we have static parameters and the dynamic parameter. Static parameters is you take a picture of the patient, and it's a static one, isn't it? It's heart rate of that particular the time, the blood pressure of that particular time, urine output of particular time is a static parameter. So dynamic parameters is that it's sort of a trend-like thing. So you are going for a trend here. So if you're giving a fluid bolus and checking what is happening to your heart rate and blood pressure, it's a dynamic parameter. So doing something and checking what happened to the hemodynamics. Okay, that is a dynamic parameter. And the other one is a passive leg raise test. Passive leg raise test is just raising your legs and you're infusing about 500 ml of blood to your central circulation. It is like giving a fluid bolus to this particular patient. Okay, so those are the dynamic parameters that we can do usually in our sports setup. That is, one is passive leg tracing test and see what happened to your heart rate, blood pressure, and the urine output, and also giving a fluid bolus and see what happening to those parameters. And other than that, in a critical care setup, we can go for measuring stroke volume variation and pulse pressure variation, and also we can do the echoes and see what is happening to our cardiac output. So those are how to measure the fluid responsiveness in the patient. The other one is that what are the perfusion endpoints? How are you going to end this? When are you going to end how decelerate this the fluid infusion? So one thing is serial lactate trends. You can do the lactate repeatedly and see whether it is coming down. If you are perfusing correctly, your lactate has to come down. And the other one is what is happening to your capillary refilling time. If you are perfusing, it will improve, isn't it? Likewise, what is happening to your urine output, mental state, the skin temperature, and oxygen, what is happening to oxygen requirement and work of breathing. What happened to the oxygen requirement and work of breathing? If you're infusing more fluid, what will happen? The lung is the first thing to get congested, isn't it? So if you're overdoing the fluids, your oxygen requirement will increase. These patients become tachypneic and their saturation tend to decrease if you're giving more fluid. Okay. So that is also endpoint of perfusion. Okay, after the acute phase, then now imagine that you have screened the patient, you thought that this is in sepsis and you are now giving fluid. After the acute phase finishes, then you are going to avoid the ongoing fluid accumulation. Then you have to come down on your fluid. You can't go on infusing like this. And then once you have achieved your the perfusion state, then there are place for active removal of fluid also. So in the newest guideline, there is a place of giving diuretics after the initial resuscitation of this patient. And also it's very important that continuously or the daily review the goals of fluid and fluid responsiveness in these patients. And what happened if the patient, in spite of the fluid resuscitation, if these patients remain hyperperfused and their BP is low, what is the next thing that you can do? Is starting ionotropes, isn't it? Sorry, vasopressors. Starting the vasopressors. So what is the first line vasopressors that we can use? It is a norepinephrine. If it is not enough, then we can go for vasopressin and finally to epinephrine, that is adrenaline. Okay, so in 2026 Surviving Sepsis Guidelines, they say that okay, you can start vasopressors peripherally. You do not have to wait until you put a central venous catheter. So if you have they are asking you to put start vasopressors in large vein, proximal to the antecubital fossa, any large vein, you can start vasopressors. And what is the MAP target? Usual MAP target is about 65 for most adult. But if the patient is more than 65, the MAP target is about 60 to 65. Okay. So this is, I just wanted to put this picture also because this patient was started on noradrenaline in a peripheral line in the dorsum of the hand. So after sometimes what has happened, the whole neck, the arm has necrosis, isn't it? So it's important that when you are starting vasopressors, start on a large vein, proximal to the antecubital fossa, preferably a neck vein. So you can get the help of our anesthetist and insert a neck vein and start vasopressors in large neck veins. And the other one is the antibiotic, something that we couldn't forget in sepsis. Antibiotics should be prompt, appropriate, and then we have to review it also. Okay, so there are, when you consider the time frame, there are 4 things that they have, the guideline is elaborating. One is if the patient is in septic shock for sure, you have to administer antibiotic within first 1 hour. Okay, there is a probable of definitive sepsis, but even the patient is not in shock, but there is a probable of definitive sepsis. Then also you have to administer antibiotic during first 1 hour. There's a possible sepsis. This is a possible sepsis. Without shock, then you can wait until 3 hours. With the clinical suspicion, you send your full blood count, CRP, and then you review, and then you can administer your antibiotic. Then if the likelihood of infection is very low without the shock, then you can just refer and see what is happening. You can closely monitor and look for the clues of non-infectious causes in this patient. If feasible, they say you can give antibiotic prior to the blood culture, but if it is not possible, you can give the antibiotic first and start the give the antibiotic first and then take the cultures later. Okay. But they say collect blood cultures as soon as possible and ideally before antibiotic, but do not delay life-saving antibiotic in shock. Okay, so even if you take the cultures or not, antibiotic has to be administered. And the other one that the 2026 guideline give as a strong recommendation is giving antibiotic as a prolonged infusion. Okay, the recommendation is that use prolonged infusion of both beta-lactams for maintenance rather than the bolus administration. They say give a bolus first, then start infusion. So it's a strong recommendation. They say that with the shock there is a change of volume of distribution and clearance, and also it's so the efficacy of these antibiotics will be depend on time it has about this minimal inhibitory concentrations. To achieve that, they are advocating us to give it as an infusion also. So this is given as a strong recommendation. So you can also practice that. And so practical sequence is giving the loading dose first, prolong or continuous maintenance infusion, and then you can de-escalate or escalate if with your cultures and other reports. And the other one that we cannot forget is the source control. Even if you give your early antibiotics and if your source is still there, patient may not be responding well. So you have to identify where the source is. So for that, you have to send the cultures, the blood cultures, urine cultures. If you have ET tube, ET secretion, sputum has to be sent. And also if there is a wound infections, deep tissue cultures has to be sent. So these has been sent and you have to identify where the source is and you have to remove the source and then continue the antibiotics. Even if you even if you give the antibiotic and source is not controlled, the efficacy is going to be very less. So there's a strong recommendation for doing the source control in septic patients. And then it comes to the oxygen therapy, and these are actually for the ICU setup. So how are you going to manage the desaturation in this patient? So they are now, rather than intubating the patient, they are giving their recommendation for high flow nasal oxygen over CPAP even, so that we can maintain our saturation target around 90 to 96 in these patients. If they are not having COPD or anything, the usual saturation target is 90 to 96. So you can go to maintain that saturation target, you can start the patient on high flow nasal oxygen and then other non-invasive the ventilation. And also if the patient is awake and if the saturation is low, you can try awake proning as well. Okay, ask the patient to stay prone and see what is happening to the saturation. If the patient require mechanical ventilation, with the features of ARDS, we are going to manage the patient as ARDS. So we are going to go for low tidal volume, about 5 to 6 ml per kg, with plateau pressure of less than 30. And if required, we go for higher breath. And if prone ventilation is required, we are going to take prone ventilation for 12 to at least 16 hours. And if there is no features of ARDS, but still the patient is hypoxic, then we are going for non-ARDS like management. We are going to go for about 6 to 8 ml per kg the tidal volumes, and we have to daily screen whether the patient is developing ARDS. In that cases, they are not recommending routine the neuromuscular blocker. They are other than that, we can go for deep sedation in this patient rather than using muscle relaxer. Okay, so the oxygen, the take-home message in this slide is oxygen target is about 90 to 96 in non-hypo, if the patient is not having COPD or bronchial asthma, and go for high flow nasal oxygen or CPAP if there is any oxygen requirement. And you can prone the awake proning also recommend. Other than that, what are the other ICU the supportive care we can do? One thing is they are recommending to give hydrocortisone if we are starting on vasopressors and if the vasopressor requirement increasing, and also with the restrictive transfusion strategy. Usually our transfusion, the target is in a critical patient is about 7 milligrams. So we are going for a restrictive transfusion strategies. I said earlier that there can be the blood glucose level can go very high. In that case, we have to go for a blood sugar level of less than 180 milligram per deciliter. And the other one, the most important one, is starting early enteral feeding in this patient. They recommended to start enteral feeding within first 72 hours if feasible. Okay, and also there are the place for the pharmacological the venous thromboembolism prophylaxis. If there is no contraindication, they are preferring low volume molecular weight heparin in sepsis scenarios. Other than that, there are things that we should avoid. One thing is that vitamin C is not routinely given for this the patient, and also antibiotic usually they are not giving to improve the outcome. And also vitamin D probiotics and even routine IV, IG and blood purification therapies and IV beta blockers for septic shock treatment is discouraged with NIVAS guideline. Okay, so what is happening if there is a refractory septic shock? That means that our patient is not responding to our antibiotics or anything. In that case, the thing that we can do is the source control. Okay, you have to do a recheck the source control, recheck the antibiotic adequacy, or whether there is any occurring bleeding, whether there is underlying myocardial dysfunction or any other adrenal insufficiency. Those causes has to be excluded if the patient is having refractory septic shock. And also in that case, depending on the pathology of the underlying cause, you have to treat. So what are the key updates mentioned in this 2026 guidelines? One thing is the sepsis code, sepsis also sepsis hurdle is that it's a sort of a bedside discussion about how to manage it. Is with the clinician, you're going to discuss about how to manage this patient properly. Okay, they are suggested and they are encouraging those sorts of the sepsis hurdle. And then pre-hospital screening if possible, before coming to the patient coming to the ward or the hospital, you're going to assess this patient and treat, and even they are advocating pre-hospital antibiotic for selected patient, and peripheral vasopressors has to be given, and after active fluid the administration, there's a possibility of removing the fluid if you find that it is more. And other than that, prolonged lectins, that's what I have told earlier, it has been upgraded, and MAP target in more than 65 patients is about 6 to 65. And corticosteroid focused on septic shock. If you are on patient is on the vasopressors, you have to start corticosteroids. And awake proline and high flow nasal oxygen is also the recommended. Against one I have already told you. Okay. And so the bedside summary for a patient with sepsis is you recognize it. You have to look at your clinical features and also your clinical features, and you see whether the features of infection is there, whether you have any organ dysfunction in this patient, and then you screen the patient. Screen the patients with your the national early warning scores and modified early warning scores. With that you screen, and then you treat. You treat with sepsis 6. Sepsis 6 has 6 things in there. And then you resuscitate the patient and reassess the patient. Okay? And in the reassessment, you need to source control, de-escalate, and think about the recovery of the patient. So first our priorities is the sepsis 6. I have told you about that, and here taking blood cultures is pretty important. And if the patient is in septic shock or probable septic, giving antibiotic is very important. And balance crystalloid for if the patient is hypovolemic and in shock. And start vasopressors if the hypotension persists despite the fluid resuscitation. And ongoing priorities are the source control, ideally within 6 hours, and dynamic assessment of the fluid responsiveness, and have to seriously monitor what is happening to your lactate and capillary refilling as the responsiveness of fluid management. And then you have to de-escalate your antibiotic as soon as possible. With that, I conclude the discussion. If you have any questions, you can ask. Sorry?
I have a few questions. Actually, one is how quickly do we need to start the vasopressor? Do we need to wait 3 hours?
No. It's not like that. First thing is giving fluid. You have to give fluids, and see with the fluids you just you usually be giving fluid at boluses. You give about 250 cc. So I said that within first 3 hours you have to give 30 ml per kg fluid, but this is given as boluses. 250 ml bolus, see what is happening. 250 ml boluses, see what is happening. Within about 2 to 3 boluses, you know whether you have to like it is responsive or not. If you think that it is not
15 minutes like bolus.
Yes, 15 minutes like bolus, depending on the cardiac status. If the patient has no underlying cardiac dysfunction, yes, 15 minutes is all right. 250 bolus.
What sort of antibiotic probably prescribe for?
It depends on the source and the current, the local guidelines.
If his focus is not identified,
Yes.
is there any broad idea, empirical antibiotic group we need?
I will yes, I will read it and let you know. Yes.
The first one is okay, no, the beta lactams.
Beta lactams is there. Yes, you can give beta lactam. It depends on the local policy and the resistant ranges of the strains that you have usually encountered.
Surgically, we usually do beta. You guys do more, yeah, respiratory,
Mm.
most of the time you do negative sides.
Yes.
Most of the time. That.
Yeah, we will. I will read about it and let you know. But I didn't like it. It says that it depends on the local the nature of the locality.
See, now the guideline recommended to do balanced crystallized as the free choice of
Choice, yes.
Now we used to do the 9.9%.
0.9%.
So some have this myth actually. When you start hard month, balanced crystallized,
Yeah.
and was high lactic. Can you
There is yeah, because one thing with the Hartmann is that it is osmolality is about 273. So it is less than the usual plasma osmolality. So there is a theoretical possibility that it can cause the the plasma osmolality can go low. Lactate level, it depends actually. It can sometimes increases, but most of the evidence in sepsis is with the 0.9% saline. Yes, because the pH of the normal saline is about 5.5. So there is a possibility of hypochloremic metabolic acidosis, but in our practice, we usually doesn't see it. So you can give. It depends on the patient. Depend on the patient's situation. Can't say, what you can do is you can do the serial lactate levels and see.
Are there for the lactate?
Yes. Yes.
That case we might be misleading.
Yes.
We are so we are not.
In that case, you can go for other parameters of pollutant like capillary filling time. They are just say that it's one of the good parameter that you can measure. Capillary filling time, and also if you can do this other dynamic things, passive leg raising and fluid challenge.
How much duration should we start with?
It is 200 milligram daily dose. So we are usually giving it as 50 milligram 6-hourly dose. That is 4 doses.
So when we start diet dose, you can start.
Not really, not with the noradrenaline. If your dose is increasing, it says about if your dose is increasing more than 0.2 microgram per kg, then you can start the hydrocortisone. And ideally, if you added another inotrope, definitely you have to vasopressin or adrenaline to the noradrenaline, then you have to start.
That means we are trying to improve the lifestyle.
Yes, because there is adrenaline insufficiency in the system, plus there is a down-regulation of beta receptors. So we are just improving those things with hydrocortisone.
Is there any medication to improve mitochondrial function?
Right.
Because we can't break it, right?
We can't break it,
yes. And the use of bicarbonate, what do you think about routine?
Yes, it is not usually appropriate. It says that if it is, if the pH is more than less than 7.2, there is a place. But when you are giving bicarbonate, what I learned was you are just targeting the extracellular spaces, and we are not looking at the intracellular the environment. So you are just treating the extracellular space. So that is not usually advocated. So because of if you're perfusing and if your renal functions are improving, then naturally bicarbonate level will go down. So, but if you think that the pH is 7.2, and if you think there's a bicarbonate levels are low, then you can give, but not routinely recommended, because that level is only in the extracellular fluid. So it increases the intracellular acidosis also, that we can't measure.
And sometimes the acidosis is actually protective mechanism.
Yes, yes.
If you correct it,
There can be problem. Yes.